Hello, and welcome to Dr. Tad Gerlinger's joint education class. We will review both hip and knee replacements in both the outpatient and inpatient surgical settings. Feel free to pause this video at any time. Class objectives include understanding why and how surgery is performed, understanding a typical hospital course, understanding a typical recovery, and discussing possible complications and how you and your surgical team can prevent these possible complications. We will begin with some knee anatomy. So the knee is made up of the femur, which is the thigh bone, the tibia, which is the shin bone, and the patella, which is the kneecap. Surrounding this is the cartilage and meniscus that provides that fluid range of motion. The four ligaments that make up the knee include the anterior and posterior cruciate ligaments and the medial and lateral collateral ligaments. Arthritis is the inflammation and destruction of the cartilage tissue. As you can see by the picture here, that degenerative joint disease taking place. The different types of knee arthritis include osteoarthritis, rheumatoid arthritis, and post-traumatic arthritis. The knee is made up of three compartments: the medial, lateral, and patellofemoral compartments. If you have arthritis in only one compartment of your knee, that is what would indicate you for a partial knee replacement or a unicompartmental knee replacement. If the arthritis has spread to two or more compartments, that would indicate you for a total knee replacement. The surgical treatment for a partial knee replacement, Dr. Gerlinger uses a Smith & Nephew implant. He will begin by preparing the bone by removing the damaged surfaces, keeping only healthy bone. He will position the oxynium cup onto the femur, the titanium tray onto the tibia, and place a highly cross-linked polyethylene plastic liner in between. These components will be cemented in place. For the surgical treatment for a total knee replacement, Dr. Gerlinger uses a Smith & Nephew implant called Legion. It is tried and true and coined as the 30-year knee. He will begin by preparing the bone by removing the damaged surfaces, keeping only healthy bone. He will position the oxynium cup onto the femur, the titanium tray onto the tibia, and place a highly cross-linked polyethylene plastic liner in between. On the back of the kneecap, he will resurface it, keeping 60 to 70% of your own bone, and place a plastic button so there's always metal rubbing on plastic. These components will be cemented in place. We will move on to hip anatomy. So the hip is made up of the femur, which is the thigh bone, the pelvis, the ball and socket joint, which include the femoral head as the ball and the acetabulum as the socket, and then the cartilage in between, providing that fluid range of motion. Again, arthritis is the inflammation and destruction of that cartilage tissue, and the types of hip arthritis include osteoarthritis, rheumatoid arthritis, post-traumatic arthritis, vascular necrosis, and congenital deformities. For the surgical treatment of a hip, Dr. Gerlinger uses a few different hip implants depending on the patient's anatomy. He will use the Smith & Nephew anthology system with an R3 cup, a Kyocera system, or the possibility of using different components like an echelon stem or dual mobility implant. He starts by removing the femoral head, which is the ball out of the ball and socket joint. He then creates a hollow center of the femur to place the metal stem. The metal stem has a press fit indentation that allows the bone to grow into it. He then places a ceramicized oxynium ball on top. After that, he will remove the damaged surfaces of the acetabulum, which is the socket of the ball and socket joint, and replaces it with a metal cup. He sometimes stabilizes it with a screw. Last, he places a plastic liner to stimulate the cartilage. The most important part for the total hip recovery would be the hip precautions, which include not bending greater than 90 degrees, not twisting the surgical leg inward, and not crossing the legs. These precautions are in place for 6 weeks while the bone heals into the implant. Dr. Gerlinger performs minimally invasive joint surgery. So for the knee, the incision is smaller than the traditional. So the incision is about 3 to 5 inches in length versus the 8 to 10 inches you may have seen before. For the hip, he does a posterior approach. He does not cut muscle. and the incision is placed over the outside of the hip. It's about 3 to 5 inches in length. The benefits of minimally invasive joint surgery include less tissue disturbance, less blood loss, less post-op pain, and a faster recovery. So we will discuss some different types of closures and dressings. There are two different types that Dr. Gerlinger uses. The first being dissolvable sutures and skin glue. On top, he will place an Aquacel AG dressing. AG stands for silver, meaning it keeps the incision clean and dry. The dressing is waterproof and designed to stay in place for 1 week. You do not need to cover it in the shower. The second option, Dr. Gerlinger would use nylon sutures and a Pravina incisional wound vac dressing. This dressing is treated the same as an Aquacel dressing. However, this bandage has a machine with tubing connected to it. It provides a vacuum seal to allow good blood flow to the surface of the skin to aid in wound healing. It is designed to stay in place for 1 week. You may shower with it, but the machine is not waterproof. We recommend either disconnecting the tubing prior to your shower or placing the machine in a Ziploc bag and placing it to the side. You will be able to remove this dressing yourself 1 week post-op. The nylon sutures will be removed at your scheduled 3-week follow-up with Dr. Gerlinger. Both dressings are removed 7 days post-op. Please peel both dressings off like a normal bandage and dispose of it. If you have the Pravina, you will dispose of the machine as well, as it is one-time use. At this point, you can leave your incision open to air as long as you keep it clean and dry. Please wash your incision gently with normal body soap like Dial and water and pat and dry. You may leave it open to air. If you prefer to cover it, we recommend gauze and an ACE wrap for knees and gauze and compression shorts for hips. No tape. Do not apply any topicals like lotions, creams, or ointments until cleared by Dr. Gerlinger. And do not submerge it into pools, hot tubs, or baths until cleared by Dr. Gerlinger. Please keep your incision clean and dry, and it should heal up perfectly. The type of anesthesia that's used, so for a knee, will be a combination of a spinal and regional anesthesia with a twilight sedation. For the hip, it's an epidural with a twilight sedation. We like this type of anesthesia because our patients wake up easier with less side effects, including nausea and vomiting, better pain control, and able to get up and move faster. General anesthesia will be indicated by your anesthesiologist. You will meet with your anesthesia team prior to your surgery in the preoperative holding area. They will be able to go over this plan of care with you in great detail. We do recommend oral hydration for better results. So the first couple of days leading up to your surgery, make sure you're getting a lot of fluid, staying well hydrated, say at least for 3 days prior to your surgery. We do ask our patients to finish 500 milliliters of Gatorade 2 hours prior to your scheduled arrival time to the hospital. If the patient forgets to do this, your surgery will not be canceled. However, this will aid in your success after your surgery. We would like for you to wash your surgical area with Hibiclens before surgery. So we ask that you wash the area the night before surgery and the morning of surgery. The Hibiclens can be purchased at any local drugstore like CVS or Walgreens. It's also called chlorhexidine gluconate solution. We ask that you do not wash your surgical incision after surgery with this Hibiclens. This is only a pre-surgical wash. So let's discuss the hospital and surgery center course. The patient will receive a pre-op telephone call from the surgery unit the business day before surgery to give the time of surgery, the time of scheduled arrival, and when to stop eating and drinking. The business day before surgery would be on a Friday for Monday surgeries, on Monday for Tuesday surgeries, and Thursday for Friday surgeries. On the day of surgery, the patient is to report to their scheduled facility for surgery. Rush University Medical Center is the only facility that is inpatient surgery. So these patients are required to stay at least 1 night in the hospital. Oak Brook, Gold Coast, and Munster are all outpatient surgery centers, and the patient will be discharged home the same day of surgery. The patient should expect to be in the pre-op holding area for about an hour and a half to 2 hours before surgery. Family is welcome in the pre-op holding area with you. This is where you will be prepped for surgery and meet with both your anesthesia and surgical teams. We will expect for you to be in the operating room for about an hour and a half to 2 hours. This will consist of administering anesthesia, positioning, opening, implanting, closing, and reversing anesthesia. Dr. Gerlinger's portion is only about 30 minutes. You will then be brought to the recovery room where you will wake up from anesthesia. This typically takes about an hour. If you are at Rush, you will then be transferred to the orthopedic floor, which is our 13 East Tower. If you are at a surgery center, this is your last stop before discharge. You will be given some lines, tubes, and drains while you're with us. So you'll be given an IV. This will be how you get your fluids and your medications while you're with us. And it's the last thing to be removed before you leave. You'll also be given a sequential compression device, which is also called an SCD boots or massaging boots. This will help pump your blood during surgery and just decrease the risk of blood clots. And then for our total knee replacements, you'll get a hemovac drain. This will help decrease pressure on the incision. Again, this is only total knee replacements, and this will be removed before you leave us. There are a few discharge requirements. So prior to your discharge, you have a few tests to pass. You will meet with a physical therapist where they will fit you for an assistive device like a walker or crutches. They will walk you around the unit and clear you on the stairs and teach you a few exercises that you can do your first week at home. The medical team will also clear you to make sure your vitals and lab work are within normal limits prior to discharge. And we will also make sure that your pain is managed appropriately prior to leaving our facilities. Cold therapy after surgery is very important. We will give you a gel ice rack that consists of 2 gel ice bags. These gel ice bags are good for 4 hours. We recommend icing 4 to 5 times a day for the first few weeks. Icing is a part of both pain and swelling therapy. If you are interested in purchasing an ice machine, you may do so at one of our DME stores here at Midwest Orthopedics. So let's discuss your postoperative pain management. So with our pain anesthesiologists in the hospital and our ortho joint surgeons, they created this multimodal schedule. Multimodal meaning that each pain medication blocks a different pain pathway in the body, and the schedule is around the clock with or without pain. So they want you to follow this schedule religiously in order to stay ahead of the pain because it's really hard to play catch up with oral medication. And we will start this regimen in the hospital with us. So the first one there is gabapentin that acts on nerve pain. It's 2 tablets every 8 hours, which would be 3 times a day, and it's prescribed for about 2 weeks. Then you have Tylenol, which is over-the-counter extra strength Tylenol for pain management. That's 2 tablets every 8 hours. It works well with the tramadol, which is a mild narcotic, and this is great for the pain management, the long-acting pain drug, and that can be 2 tablets every 8 hours. We also prescribe the loxicam, which is an anti-inflammatory. That's once a day after a meal. And then the oxycodone is going to be your severe breakthrough pain management drug. This can be taken 1 to 2 tablets every 4 to 6 hours as needed for severe breakthrough pain. We do recommend spacing this out from the tramadol by at least 1 hour so that you don't have those same side effects of nausea, vomiting, or fogginess. We will prescribe a blood thinner for all patients to help prevent blood clots after surgery. Our standard regimen is the aspirin, 81 milligrams, which is a baby aspirin twice a day for 30 days. This totally depends on patient's history too. If you were previously on a blood thinner or you have some pre-existing conditions, we may change this up. And we will prescribe a stool softener as being on the opioids or narcotics. Constipation is a very common side effect. So lots of fluid fiber and a stool softener will help that. And then for our outpatient surgery candidates, You will receive an antibiotic, which would be the ceftriaxone, which would be twice a day for 10 days, and an anti-nausea medication, just in case, since you're going home, we do like to do these preventative courses. Physical therapy after discharge. Dr. Gerlinger will write you an order for physical therapy to begin outpatient 7 to 10 days after surgery, 2 to 3 times a week for about 4 to 6 weeks. He recommends our Midwest orthopedic physical therapy locations. We have a map of location listed on Dr. Gerlinger's website and our Midwest orthopedic website. The patient is responsible for making these appointments. If you find a different location you would prefer to go to, we would be happy to fax an order to this facility for you. There will also be a paper copy in your discharge paperwork. The first week after surgery, Dr. Gerlinger would like for you to practice the light stretches and exercises that were taught to you at the hospital without overdoing it and allowing proper healing and allowing the swelling to come down. Dr. Gerlinger will not prescribe any home therapists to come to the house for this reason. The follow-up visits after your surgery includes a 3-week post-op check. So this will be a wound check, x-rays for our knee replacements, and nylon sutures for those who have them. You'll get a 6-week post-op check. This will be x-rays for everybody and clearance to resume some normal activities. And then an annual appointment or as needed. Telemedicine visits are available upon request. You may also do these visits with our nurse practitioner, Alyssa Winter. She's located at our Midwest orthopedic locations, and her schedule will also be given when given the opportunity to schedule these follow-up appointments. Please contact Dr. Gerlinger's office to schedule with her, and she's also available to do telemedicine telemedicine appointments with her. Common questions we get are, when can I return to work? So if you have a light duty desk job, about 2 to 4 weeks post-op would be appropriate. For more heavy duty, labor intensive jobs, about 6 to 8 weeks post-op would be appropriate. And if you do provide us with FMLA paperwork, we will write you off for the full 12 weeks, and you can request a return to work letter when you are ready to go back. As far as driving, Dr. Gerlinger has done a study that shows your brake reflex comes back 2 weeks after surgery. So if you are off the narcotics, including the tramadol and oxycodone, and feel safe behind the wheel, you are welcome to resume driving at 2 weeks post-op. For flying, we prefer for you to fly after the 3-week wound check appointment. No implant cards are required anymore. All you have to do is let your TSA agent know that you have a metal implant and go through the scanner where you put your arms above your head. As far as returning to activities and normal exercises, typically by that 6-week appointment, we clear you to do this. At 6 weeks, we expect you to be about 75% healed and reaching 100% at that year mark. We do want you to ease into these activities, allowing yourself to adjust and get back to your normal self, and no high impact activities like running, jumping, tennis, or pickleball until that 3-month mark would be a safe option. And then if you do need your other knee or hip replaced, we do have a minimum of 6 weeks between surgeries. So for potential risks and complications, this is a big one. So infection is a risk following a joint replacement. However, with Dr. Gerlinger, it is less than 1%. That is because we do a lot to avoid infection. First, we make sure you are medically optimized by a rush internist to rule out any potential infection risks. We recommend you wash your surgical area with Hibiclens the night before surgery and the morning of to remove any bacteria on the surface of the skin. This can be purchased over the counter at any local drugstore like Walgreens or CVS. You will be given a full course of IV antibiotics at the hospital and a private room, so no pesky neighbors coughing or sneezing near you. We do encourage short hospital stays to avoid hospital-acquired infections and create floor goals to discharge you safely and effectively. And most importantly, we put our dental prophylaxis in place. Dr. Gerlinger recommends no dental cleanings or dental work to be done 3 weeks before surgery or 3 months after surgery to avoid infection. This is because bacteria builds up in the mouth, and when the dentist is poking in there, they are creating entryways for the bacteria to enter the bloodstream, in which they like to colonize onto artificial implants, including hips and knees. Therefore, Dr. Grolinger has a lifelong recommendation to take an oral antibiotic 1 hour before any dental appointment to avoid this infection. Blood clots are another risk, including deep vein thrombosis and pulmonary embolisms. We will teach you what to look for and also put you on a blood thinner and get you up and walking soon after surgery to promote good blood flow. Hematomas are a blood accumulation in the joint space. Dr. Gerlinger will place a surgical compression dressing on your site to avoid this. Hemovac drains will be placed in total knee replacements and will be removed prior to discharge. You are at risk for loosening or failure of an implant if you do too much too soon. You cannot heal yourself faster, and it will be important that you take it easy and give your body proper recovery time to avoid significant issues. Low impact exercises include walking, biking, hiking, swimming, dancing, and elliptical, which are recommended with your new joint once healed. High impact activities like jumping, running, tennis, pickleball, and hockey can begin after the 3 month mark once cleared by Dr. Gerlinger. You are at potential risk for residual pain and stiffness and for fractures with any falls, so always notify the office with any falls or concerns. You are at risk for nerve injury with any lower extremity orthopedic surgery, including perineal nerve damage or drop foot. There is an increased risk for perineal nerve injury with preoperative valgus knock-knee deformity. Blood loss in surgery is very minimal. Dr. Gerlinger loses about 2 to 3 small little medicine cups of blood. This is why we do not have you donate blood before surgery, as you put yourself at more postoperative risk with blood depletion. We will give you blood if indicated in surgery. However, it is very rare. Some patients report a clicking sensation after surgery. There is now plastic and metal rubbing on each other, which can cause this, but also swelling can cause the sensation as well. Once the inflammation goes down, this typically fades away. Leg length discrepancy can sometimes be noticed when the surgical leg feels longer than the non-operative leg. During surgery, Dr. Gerlinger corrects the angle of deformity and makes you straight. This may make you feel longer or taller, but this sensation comes out when the patient has worn out a joint, causing alignment issues. Dr. Gerlinger does not make you taller, but he does make you straight. This will feel normal after proper gait training and stretching out the ligaments and muscles. Insomnia can be present in those that do not practice good sleep hygiene. If you are having trouble sleeping at night, Dr. Gerlinger recommends not taking naps during the day, avoiding caffeine, icing down the joint about 30 to 60 minutes before sleep, limiting activities after 4 p.m., and replacing your Tylenol dose at night with Tylenol PM or melatonin. Symptoms after surgery. So common symptoms would include lots of swelling and bruising throughout the entire surgical leg. We do expect your surgical leg to get twice the size of your non-surgical leg, with bruising and swelling from the hips down to the toes, whether that be a hip or a knee replacement. This will come down with time, but all that's very normal. It typically comes out about 48 to 72 hours after surgery. That's when your inflammatory response peaks. You might start to notice a little bit of warmth, redness, some low-grade fevers, less than 101.5. All of this would be very normal. Things that are abnormal would be if your calf muscle is extremely painful, tender, swollen, red, hard. This could be a blood clot. We would need to know about this right away. Any chest pain or shortness of breath, straight to the emergency room. And then any signs or symptoms of infection, including fevers greater than 101.5, total body chills, significant drainage, spreading redness, past foul smells, spreading redness. Things that all just don't smell or look right. Please always call us, send us photos. That's what we're here for. We want to know about this immediately. If you haven't already, we strongly recommend signing up for Dr. Gerlinger's surgery text. Our patients really love this and find the text to be very informative throughout their entire perioperative journey. So all you have to do is text join to the number there and follow the prompts to enroll. It's a great little system that we have going. There is an optional nutrition package available for purchase. It's called the EMN Orthopedic Nutrition Bundle. These are some protein shakes that are supposed to help with supporting lean muscle mass and wound healing after surgery. These are not meant to be meal replacements. They're meant to be some extra protein supplementation throughout the day. It's designed for 2 weeks before surgery and 2 weeks after surgery. And there's two flavors, vanilla bean and decaf cold brew. So you can purchase this at one of our durable medical equipment stores, our DME store, or online at this website here. So what do you do now? How do you prepare for your surgery? So first, you will stop your medications as directed by your rush internist. They'll go through your entire list and tell you which ones to hold before surgery. Prepare your living arrangements as accordingly. Just remove any rugs that might be, bundled up, anything you can trip over. Sign up for our surgical tech. Start your protein supplement if you're going to do that, completely optional. Schedule physical therapy to begin 1 week after surgery. Wash your surgical area with Hibiclens. Stay well hydrated and eat nutritious meals. And relax and know that you are in great hands. So thank you for your time. Thank you for reviewing this video. Please share it with your family or friends who are going to be along with you on this fantastic journey. And give us a call if you have any questions. We are happy to help and we look forward to taking care of you. Thank you.